Hello and welcome to Aging Matters. This is a show that is presented by and sponsored by the Berks County Area Agency on Aging. My name is Ann Barlet. I'm the Public Advocacy and Outreach Manager for the agency. Tonight's show is regarding the Caron Treatment Program for seniors, and my guest with me tonight is Sharon Matthew, who is the Clinical Supervisor of the Seniors Program at Caron Treatment Center. Welcome, Sharon.
Thank you so much, Ann.
Thank you. I'm really excited. I'm fascinated with this. I think it's an area that maybe we don't think about or don't know about for certain. And there you are up on that hill. and we want to know more. So I'm going to start right in with talking about, when we say the seniors program at Caron Treatment, why? What's the background? Why? Obviously, there was a need. Something was identified. So tell me a little bit about the beginnings and the background of that.
We began February of 2015, and the need is we see a growing population of people in need of these services. Since 2008, there's been a tremendous influx of patients going in for treatment in this population. And we also know people are living longer. 13% of the U.S. population is over 65, and 17% of those used or abused drugs and alcohol, which is a pretty big percentage. For the next 18 years, boomers will be turning 65 at a rate of 18,000 a day. So I tell people, I just spoke in Atlanta, get your doors ready, get them open, because this population will be in need of treatment. There's many things that fuel that, which I'll talk about, but in the next few years, of course, there will also be more boomers and seniors than children in the United States. 1/3 of the prescription medications prescribed are prescribed for older adults, and then 2/3 of the over-counter medications are taken by older adults. This also complicates things tremendously.
Well, I think we have different ideas and concepts of people needing treatment, and you're mentioning, over-the-counter medications. So there's a big mix of the purpose, the need for treatment, of why somebody would have gotten themselves or would have been in this mix of complications, whether they be younger or older. And this program in particular, as you said, with the statistics, have identified that as being, we say older adult or senior. What is that senior for your senior program? Do you have an age for that where that makes a distinction?
We are treating people from 60 to 90. I actually treated 2 90-year-old females, which was awesome to see. As people age, they have normal medical problems, oftentimes heart problems, diabetes, could be chronic pain. But then, and they might have been functioning just fine with maybe drinking some wine once in a while or being given a medication by the doctor. But then these things can be exacerbated by the normal aging process. And as we know, people don't bounce back as quickly. So many of this population was functioning okay until they were not. And what we see is the caregivers, their loved ones, most of our referrals are by the adult children of the alcoholic or addict who are scared and don't know what to do anymore, and they're finding that their loved ones are not functioning, their activities of daily living are going down the drain, or they also might have vision problems, hearing problems. All of these are so exacerbated by the drugs and alcohol. And then they don't understand sometimes the mix of drinking and then taking maybe a benzodiazepine for anxiety or depression. This is a population too that has tremendous loss, grief and loss, and it's not just about losing a loved one. It is about losing their station in life. Most of them are retired. Many have raised their children. What to do? I have too much time on my hands. A lot of sadness. So everyone in our unit goes to a grief and loss group for that reason.
Well, don't you think too, Sharon, that the piece of it is also is that maybe I was, as you said, maybe able to manage. So at 40 years old or 45 or 50, I may have had the same issues in terms of the way I'm starting to take meds, whether it was because of pain, because I had a car accident, or whether it was, happy hours and things like that we start, and so that's not new in terms of that the behaviors or the habits, but now all of a sudden we're adding 20 years.
Yes.
And so we happen to get to the age of 60 and older and still have those habits, but now, as you started to allude to, you know, besides having the years of those behaviors or habits or whatever, we have aging issues, right? So
Yes.
maybe we can talk, let's talk a little bit more about what you're seeing in terms of, you know, we know what we're seeing in the area agency and
Right.
aging with folks who are aging with the regular various diagnoses that they have, the various ailments or complaints or issues that are going on even without some form of addiction.
Right.
So let's talk about aging itself with the addiction. A little bit more about that.
And as I had mentioned, the bodies don't bounce back like
Right.
they might have when they were younger, so the withdrawal process is quite extensive.
Oh.
So I will say that the medical component is just totally excellent with what we do. The doctor safely withdraws them from chemicals. We do an interdisciplinary approach, so it's medical, psychological, spiritual, nutritional, recreational, and also then the family component. But when they first come in, that withdrawal process takes longer than someone who is younger because your body does not metabolize like it might have done before. So that is why we have a very safe, small, secure unit. Everybody is assigned an aide when they first get there.
okay.
It could be 24/7, but then we wean that down as they get better. It's wonderful to watch people coming in on a wheelchair and then going to a walker and then a cane and then being able to walk on their own. It's just fantastic to see. So I do believe that healing process is working. Are they resistant at first? Absolutely. There's a tremendous amount of denial with this population. They think that they were doing okay. And then what we get is the letters from the family that says, but you really weren't doing okay. So we use that leverage a lot. Oftentimes someone will say, well, I really don't need this. I'm not like everybody else. And then the family tells us exactly why they need to be there. So that's what we use as leverage, in fact, to keep someone there. And then we're also seeing 6 weeks length of stay is almost necessary. 4 weeks is the normal
not
for
quite
inpatient.
enough.
It's just not enough because of that longer process. We meet them where they are. We slow the pace down. So if they can't go to a group or a lecture a particular day, that's fine. They can rest in their rooms. As I said, we meet them where they are.
So I do want to mention, so we have some aging. You mentioned about medications, mixing and aging with other chronic conditions. Talk a little bit about those areas, I guess, that you're seeing are pieces of why this is needing for treatment, what has gone on in their lives with medical needs, and then the habits or the behaviors.
Well, as we know, if they are, say, taking an antidepressant and then you're using alcohol, that is a double whammy. We have a lot of people, alcohol is still the first drug of choice, if you will, but then benzodiazepines like Xanax or Valium are coming a close second, oftentimes prescribed by a doctor because they are anxious or sad or depressed. And then the withdrawal from that, and we've treated a lot of people have been on those for a long time, and that is a very long drawn out withdrawal process. So again, they have to be tapered off of a medication safely so that they wouldn't have a seizure. I've seen that happen, go on for like 3 weeks at times. I can't mention enough, and the body itself, the kidneys, the lungs, the liver, a lot of sometimes late stage alcoholics having cirrhosis of the liver, and it's sneaky. And sometimes, when I said the ages are 60 to 90, we've also treated people in their 50s on that unit because of either cognitive decline or the physical decline because of the progression of their disease. And what we believe is that the level of denial equals the level of the progression of the illness. So that shows sometimes when they're sicker.
Okay, so give me a generic person who might be coming there, what their typical medical condition might be, and then what happens, so that I have a good understanding of who's most appropriate, I guess.
Well, oftentimes they will come in and they're pretty shaky when they start withdrawing from the alcohol. They're very scared. Those who have chronic pain are thinking, how am I going to get off these opiates? I've been on this for a long time. I'm going to have too much pain. I cannot do this.
Well, and I would think it also, let's just say pain of the back or the knee, or the, then they're thinking, if I can't do that, how am I going to function? I'm not, and all of the worries then set in, okay?
Right. So again, the medical piece is, we have a marvelous doctor who is on that unit and sees them every day. The nurse is on that unit. She is there for them, asks the questions. There's a lot of questions with this population. What about this? What about this? If you want to take, for instance, we have med carts, in each unit. This unit has 2 med carts. That's how many medications are involved, even as they're getting better. Agitation, you will see the staggered gait because they're just compromised.
Okay. So let's break down, if we can, then types of the treatments. You gave us a broad picture, but let's break down what the medical piece. If I need to come. We've acknowledged the fact that as an individual, I'm going to come maybe reluctantly.
Exactly.
And you have an intake, and you're assessing all kinds of things. So let's go from that intake point of what you're assessing, and then all of the pieces that you said, the components that would be part of my treatment. And I'm assuming also that all of the folks are unique in their treatment, because they're all a little different, even though they're this age with a similar situation.
Right.
Everybody is different.
Right.
So if you could really share those specifics with us.
It begins with the intake is with the families usually to get them into treatment. And then once they are in treatment, they go through a nursing assessment. Then they have a history and physical with the doctor. And then the counselors do a biopsychosocial on them to get a further history on them. A lot of collateral information is gained through the families, because they oftentimes will not either remember or won't be exactly upfront with what's really going on with them. From that information, we develop a treatment plan for them. We take it slow again, basically working on steps 1, 2, and 3. Now, I do get sometimes a relapse patient, someone who had treatment before, who is a little more savvy and understands the disease concept. We do a lot of education around the disease. But their day starts with wellness in the morning, so the wellness team comes and does either yoga or mindfulness or dance and movement. And that is really well received. They love getting started that way. These are people who have been isolating oft times in their homes and not doing a lot of moving around. It gets them up and going. And then we have a small group in the morning where they'll process some things. This is also a population that must be treated with dignity and respect and non-confrontational approach, because they won't have it. It's also, and I don't mean this weirdly, but stubborn. They're a little stubborn and set in their ways.
I was going to say, I'm amazed that they like to get their morning to mix with people, because, again, some are hesitant even to enter like senior centers or things like that for different reasons. They may say, it's because I'm not old, but sometimes it's because they're afraid to go. They're not sure how they're going to be received by the other people that are already there, or what exactly happens there. So just knowing that, I would imagine that obviously that comes along when you go to something like that, where you're going to be mixed with people that you don't know either.
Well, the thing that works with this population is the commonalities, them coming from the same sort of mindset, the same kind of cultural background, understanding the same language, the same music, not being with kids, if you want to call them that, people in their 20s or 30s. And that seems to put them at ease somewhat. And 2, this is a population that is private. They are not used to talking about their histories, their family of origin, any kind of trauma. And then once they get to us, sometimes they open up, and it's really great to see that they're willing. But that all takes rapport building and all of that.
Well, and to reveal that, I would think that it's not just that whatever may have been going on may have been from way back.
Way back.
That they were not told to talk about.
Exactly.
So they have put that behind them somewhere about the way they were raised or occurrences over time. And that was the age, too, where they didn't talk about that, and you moved forward. And now it's been there for all these years. And then as they moved through age, other things occur, certainly,
Exactly. So we try to lift the shame and take it away from it being a moral issue, and really educate them that this is an illness, this was not your fault. It is a progressive disease, and most likely someone in the family, and that's what you try to get back to the family of origin. Some were raised in an alcoholic home, and then we get them to be a little more comfortable about talking about that and the messages, the family messages. So I'm seeing a lot of, with this population, there is success because they tend to follow direction. Once they get in there and get settled, they tend to follow direction, and the family, again, that's who oftentimes, and we don't care where the motivation starts, and if that's the motivation, that's fine. Sometimes they're given an ultimatum, you can't be with your grandchildren if you don't get sober, we're not having this anymore. So we then, the surround services, when they're leaving, then the continuing care is very intensive as well. They're going usually to a psychologist or an addiction psychiatrist. 12-step meetings, we introduce them to that. We also bring in 12-step speakers who are of their same age, and they tend to like that a lot. They can take that, listening to someone who's been down that same road. Exactly.
Well, I would think too that again, knowing some of the situations of calls that we get for older adults living in their home or whatever, I would think that also this program, one of the components, they probably begin to eat healthier. I bet that nutrition plays a key role too. If you can talk about how you address maybe the nutrition piece that we don't think about,
That is done with, we have a nutritionist assigned to the unit, and she talks to them about healthy eating, because many have just been depending on their alcohol and certainly not been eating healthy foods.
Well, and again, even as an older adult, sometimes it's just as simple, we talk to them about, did you have toast again for supper? Because it's simple, it's easy, or soup, or, well, I didn't do that. They,
especially when they live alone.
Living alone, and it's, they just do.
That's right.
So I would imagine certainly that's carrying over. So I would appreciate probably somebody there that is really saying it's okay. Maybe make this and freeze it, or make a bunch of things and be able to have some healthy foods.
And two, the social aspect, we have a really great dining room, so we encourage, even though sometimes they're resistant, breakfast, lunch, and dinner, and they can sit together and talk together, and that sometimes starts the socialization, which is great. And then, as I said, we are such an interdisciplinary team that every week we talk as a team with all those disciplines coming in the same room and seeing what's going on with them, and getting everybody's input, and then individually meeting with them. Spirituality is huge as well.
I was going to say, I don't want to miss any components.
Spirituality is huge. They love meeting with our spiritual consultant, and then she will run the grief and loss group weekly.
So they meet individually?
Yes.
And
not only with their counselor, but also with that person, and also the psychologist, who will do cognitive testing when they first come in. And then if he sees some type of deficit, then he will retest them at the end to see, is this working? Have they gotten something? And oftentimes you will definitely see an improvement by the end. So as I said, the continuing care piece is huge, and then we cannot forget the caregivers. They are so worn out. The burnout rate for caregivers is tremendous. They are tired, they are frustrated, they are angry, they don't know what to do anymore. They are neglecting possibly things at their job if they're working. They do not take care of themselves physically or mentally or emotionally. Sometimes they start using medications as a direct result of this. We also see the risk factors are the fact that we might have an old caregiver with an older adult in the house, and then their adult child in the house. That's called the sandwich generation. And then the club sandwich generation is that caregiver with an older adult in the house, their adult child in the house, and their grandchildren. And that's becoming more frequent and more prevalent.
Yes.
And how do you manage all that? We always say take your oxygen first. And we as caregivers need to do that in the healthcare professional. If you don't take care of yourself, you have nothing left for anybody else.
Right.
So we get them engaged through family sessions, and the family program is excellent. That's
so this
a 5-day
is a separate program for those caregivers who want to participate. It's an option.
Yes, because sometimes you'll see resistant. They give them to us and they say, here, make it better, and then I'll see you in 6 weeks. But they do like phone calls, they'll be on the phone.
Updating.
But with adult children, they also live across the United States. So sometimes it's not easy for them to get off from their jobs and that kind of thing. But it's really important.
So they choose to, then you try to accommodate these group meetings or whatever, so that they might be able to get there, and they can share.
just do a weekend, which is
Oh, okay.
helpful. Then they'll get educated, but then Monday, Tuesday, and Wednesday they do everything with the patient. That's very interesting.
So you have the caregiver then also come back into the mix
Yes.
with the person being treated.
Yes. And now
Interesting.
we're
And that's
going
how to
to
dialogue? Is it how to
It's
accept
talking,
an individual?
it's talking about it's talking about communication,
Okay.
learning how to communicate and be honest with your feelings and letting them know, and also setting boundaries. You really have to set boundaries to say, you know what, we can't watch this anymore, I can't watch you die, something has to change, and that kind of stuff. We are also now seeing the need. We're going to have a caregiver workshop in October. We're going to run that every 4 months, I think it is, just for the caregivers to come and take care of themselves and get nourished. So
Good.
that will be on campus
And
as
give
well.
them almost the same
Exactly.
tips as far as taking care of
Exactly.
yourself and eating healthy and probably exercising and
Exactly.
communication.
And expression of feelings.
So I was going to ask you if there's education also. Let's go back a little bit to the person in treatment. I know it's constant education in terms
Yes.
of the processing and the talking and all of those, but there also, I would think, you were mentioning it earlier about the end part, you know, as we near the end of our 6 weeks.
Right.
And we're getting ready, you know, are we educating them as far as the, you know, okay, I've been great here and I've had the support
Absolutely.
and so on, and even the meetings maybe out once I'm in the community again, but do I understand my body and the process and what I'm doing when I do that, and how do I remain to eat healthy,
Yes.
and how do I remain mentally healthy to take care of myself?
Absolutely.
Okay.
It's really well planned. They get a recovery action plan, and that will all be written on there, and what they need to do for themselves and what they need to avoid. Also, the nurse does an excellent job of educating them on what medications are not good for them, and the doctor does that as well. She will also call their physician and
Okay.
let them know, because not everybody's an addiction physician either.
Of course not.
ASAM doctors, what they are, or the psychiatrist.
Well, and again, you're talking a lot of older, if they're the older adult who not only has the primary care doctor, but may have many specialists.
Exactly.
Certainly, they may not even be aware that the
Yes.
individual has taken the step
Right.
to go for treatment, and need to be aware, I assume, based on what they might prescribe,
Yes.
or an opportunity to change what they've prescribed
Yes.
now that.
So that too is collaboration. We call them before they leave, and we also send them the discharge summary so they'll know exactly what we did for them while they were in treatment. One thing I just wanted to say is we believe it's never too late to develop an addiction. We think it's also never too late to intervene on one, and it's surely never too late to get sober. What we're trying to do is give them quality of life, because when they come in, it is no longer quality of life that we're hearing from the kids. So seeing them come back to health is absolutely fantastic.
And you're never too old
Yeah.
to take that step.
Exactly.
To get help, you know.
Exactly.
You know, you can hear people say, "Oh, it's too late for me. I'm
No.
too old." You know.
No, when you think of the 90-year-old, one came from Florida in the middle of winter because her family said, we need to do
Wow.
something with you. And we were so impressed by her. And I don't know how she's done since she's returned home. And that's always the risk of relapse. Relapse is a part of this disease. So, but the better you make the plans, the better the chance.
And let me ask you then, just for somebody like her, whether it's the distance of Florida or just in our own county, they've gone out with the plan. You're making connections in the community.
Yes.
Should they need some resources in their community?
We give them 12-step contacts before they
Okay.
leave. They also, some go on to assisted living. Some will, as I said, have a psychologist, and including the family in all of that planning is absolutely necessary, because how are they going to get there? Most
Right.
of them do not drive at that point. And there's a lot of willingness there. The families are willing to do, well, we'll
can do this
step
part,
up.
yeah.
You bet. You bet.
Okay, all righty. So we talked a little bit about the 6-week length of stay, and all of the components, and the interdisciplinary team, I believe, and the education. How about the big question that we all have is how do I pay for this? You know, it's very important, and we should put that first, I believe.
Right.
But that's a true concern and question.
When they call the admission specialist, and we have some excellent people working, not only with other populations, but especially with this population, who are very sensitive to that. Most of our clients are private pay, but sometimes insurance is accepted, so they will run that for them. Depending on their income, scholarship dollars possibly could be given. In Berks County, we do have things called Berks County beds, and there's so X amount of those per month.
Okay.
So we try to sort of help them because we see such a need for the treatment.
And hopefully that won't be a barrier to calling. And so you said it was a small unit. How big is it?
It's 10 beds,
Okay.
All private rooms, because
Okay.
what we found early on, we saved some rooms that had 2 beds in them, but this population doesn't want a roommate,
No,
so they're not having it.
Okay.
So we are 10 beds, and
Okay.
as I said, it's all on one floor, and then the dining room is right below us, so we have a elevator that takes them right down to the dining room, so it's all like in one place.
Okay, so it's very maneuverable.
As they get better, we certainly can get them to the lectures, and that's in our auditorium. Some are carted. We do have carts that we drive them around in. Some like finally getting up and moving and walking, then an aide will help them with that, or a counselor assistant.
And I would think they would start feeling better to want
Absolutely.
to do that.
And a part of that healing is also sometimes people, especially if they have chronic pain, I have a chronic pain group as well, they will have massage or acupuncture, and we now brought physical therapy to the mountain.
Good.
Because we were taking them there, and that was a little problematic, so now they come right there.
So it sounds really a very holistic approach,
Yep.
including all of these various components of health and well-being
Absolutely.
and preparation back into the community. You've got the caregiver component of that as well, and I think that's great. We have probably 1 minute yet, Sharon. I know we could have had an hour. But in this 1 minute, I think that what we really want to share with the viewing audience is, how do I find you? Who can I call? What's our contact information?
The contact is 1-800-678-2332, and they just have to ask for an admissions specialist.
Okay.
They can also ask for me. I oftentimes will answer the family questions because they are scared. I don't, their precious material is their family member,
Yep.
and how are you going to treat them?
How do
and
I approach and how do I
it's
start
amazing.
even?
I've also done tours. Some people will come and say, well, I'd like to see it first. We've absolutely done that, and that has turned into some admissions, just knowing that it's really going to be okay.
And I feel good about seeing it.
And then our website is caron.org.
Okay.
And all of the programs, especially this one as well, is listed on
So I can look it up and
Absolutely.
look at it first and call you and make an appointment.
Yes.
Excellent. I think it's a great, certainly needed program, but I
very
think
much
well
so.
designed, and hopefully folks, if they have any questions, to give Sharon a call at the Caron Treatment Center, or you're welcome to call me, Ann Barlet, at the Berks County Area Agency on Aging at 610-478-6500. Thanks for watching our show. See you next month.